Alright, so we're going to go ahead and get started. Last week we left off with alterations of tissue perfusion. We did the A&P stuff, probably a little more in depth than what we necessarily needed to, but now we're going to kind of move into the alterations. So you've learned the normal, now you're going to see some of the abnormal things that we would look for. Alright, so as we talked about last week, why do we need oxygen? Well, cells and tissues have to have oxygen to survive, right? What happens if a cell is deprived of oxygen? It's going to die. And I keep emphasizing that point for a reason. You know, it's you deprive your patient of oxygen, you know, they're eventually going to have tissue death, and that's not something we want to work on. Normal oxygen content in just a normal setting. So hopefully in this setting, the oxygen concentration in the room is about 21%. Okay. What would make that, or what would alter that? Anybody got a guess? Okay, fire, absolutely. Fire's going to pull oxygen out of the air, absolutely. Anything else? Okay. If you have an enclosed space and you have, well, a bunch of people breathing in and out, well, you're going to have more CO2. Okay, because what is CO2? Carbon dioxide. It's the waste, right? Tissue waste. All right. So if you have an enclosed space with a lot of people, you can kind of lose your oxygen concentration. What else? There you go, altitude. Okay. As we go higher in altitude, what happens?
It's harder to breathe.
Okay. It's harder to breathe, but why?
The air's thinner.
Okay. The air's thinner, but what is it thinner? What happens with the air? Why is it more thin? We've got a reduced concentration of oxygen, right? So we have to breathe faster, breathe in more air to be able to get the same amount of oxygen. There you go, until your body kind of adapts. But still, it's still having to work off of a lower concentration of oxygen. All right. Now, respiratory, cardiovascular, and hematologic systems must work together. That's why, yeah, this is a respiratory content, but we're going to talk about some cardiac principles as well. You got to have all three of those working together. If not, if you got an alteration in one, you're going to see the results usually in some type of respiratory or breathing. You know, they're going to have a breathing response. Okay. Oxygen therapy can be used to improve oxygenation and tissue perfusion when the need of a patient cannot be met by room air or the normal 21% concentration alone. Okay. All right, some other alterations. We'll talk about supplemental oxygen is a drug. Okay, so when you are answering questions, what do you need to consider with that? Okay, yeah, who can delegate it? Okay, but who's the person that can delegate or order that? The doctor. You got to have a physician or medical practitioner with prescribing, prescribing authority. So if you do not have oxygen ordered, by definition or as far as answering a question, can you give oxygen? No. Now, practically, in a practical setting, your patient's in respiratory distress, you're going to give some oxygen, okay? And then what are you going to do? You're going to get an order for that, okay? But as far as a test question goes, you can't assume that they always have that oxygen ordered, okay? So you've got to do nursing interventions first, right? What are some nursing? If I walk in the room and my patient is struggling to breathe, what am I going to do? Sit the head of the bed up, unless there's some contraindication, right? What are some contraindications? Okay, a head injury. What else? Okay, cerebral edema, spine. So we talk about head injury, spinal injury, anything like that, anything that would prevent us from raising the head of the bed. Okay, what else? What about a physician's order that says keep it flat? Yeah, I mean, you've got to think about that as well. If the patient has specific orders on, how much they need to elevate the bed, or if they have an order for 45 degrees, well, you need to leave it 45 degrees. Okay, those are just things. But But again, raise the head of the bed unless there's some contraindication against that. All right. Oxygen is also used to resolve both acute and chronic problems that result in adequate oxygen levels in the tissues and the cells. Now, the purpose of oxygen therapy is to relieve hypoxemia, and hypoxemia is low levels of oxygen in the blood. That little emia at the end of it, that's going to be your big clue there. Anytime you see emia, it's in the blood. Okay. Hypoxia is decreased tissue oxygenation. Now, it's important to distinguish between those two. Yeah, they go hand in hand, but one indicates lack of oxygen in the tissues. One indicates lack of oxygen in the blood. Okay? Hypoxemia will always lead to hypoxia if it's not taken care of. All right? Now, our goal for oxygen therapy is to use the lowest fraction of inspired oxygen for acceptable blood oxygen level without causing harmful side effects. Okay? It's important to remember, we're going to use the lowest amount or the least amount of oxygen we can to bring the patient back up to where they've got normal oxygen levels in the blood. Okay? And we'll talk about these harmful side effects in here in just a minute. Well, let's talk about it right now. There are some complications of oxygen therapy. You think, okay, everybody's got to have oxygen. There's no reason why that would be there would be a complication or side effect. Well, yeah, there are. You can have too much oxygen. Okay, too high of a percentage over a longer period of time. Some of these issues, well, first off, combustion. All right, oxygen. Well, oxygen's not flammable, but it enhances combustion. All right, there's a reason why. Well, out west you've got the wildfires that go on. Well, what happens when the wind starts picking up? Fans the flames. You've heard that, right? Fans the flames. It's going to enhance that risk of combustion. So, what do we need to educate the patient on who is on oxygen? There you go. No smoking. Yeah, no bonfires. Keep it away from open flames. Even be careful while they're cooking. Okay, if say they're cooking with a gas stove or something like that, you need to be careful with those things. I always tell a story. I went to school down in Birmingham, and we had to walk everywhere. So I know y'all got a campus that's kind of spread out, but y'all are focused right here on this main building, right? We would have to park basically at the nursing school, and we would walk to about 4 or 5 different hospitals all around where we were. I remember I walked down the street one day, and there's a lady with a stroller. I assume it was a grandmother. She's a little bit older. Stroller, kid in the stroller. She's got oxygen tank sitting up on top of the stroller while she's smoking a cigarette. Yeah, I had to say something. So, hey, lady, you got to put that out. You know, it's gonna blow up everybody on the sidewalk. Okay, it's dangerous. So you got to make sure that the patients are aware of that. Now, some of the other issues. Well, we've got oxygen-induced hypoventilation. Hypercarbia is the retention of CO2. Okay, retention of CO2, and also you've got CO2 narcosis. This is the loss of sensitivity to high levels of CO2. A lot of your chronic patients, particularly those with COPD, CO2 is kind of important. We want to get rid of it, but also our body, especially our brain, picks up on levels of CO2. It determines, okay, we've got too much CO2, so what are we going to do? Well, what do you think we're going to do? If we've got too much CO2 in the body, what's our brain going to tell us to do? Breathe faster. There you go, faster. We want to breathe out faster, so we release more CO2. Okay? Now, over time, especially with chronic patients, they lose that sensitivity. So if the brain does not, well, they've had this high level of CO2 for an extended period of time, the brain finally says, all right, live with it. You know, I'm not picking it up. We're not going to keep increasing respirations, so that they lose that ability to increase respirations and respond to that CO2. Okay. Next, we've got oxygen toxicity. Toxicity Well, if you've got a patient on 50% or greater CO2, or I'm sorry, not CO2, FiO2, for an extended period of time, usually 24 to 48 hours, you really need to monitor for possible oxygen toxicity. Some of the manifestations you'll see. I don't think I've got this on the next slide. Yeah, some of the manifestations, you need to know these. Okay. Constant non-productive cough. Okay. Usually it's a new onset cough that's constant and non-productive. Just as dry cough, dry hacking cough that comes out of nowhere. All right. That's going to be your number one sign. Probably what you'll see first. Okay. Also, you've got dyspnea. They just can't get enough. They're sitting there. They're still struggling to breathe. You keep increasing O2, and it makes the problem worse. Okay. I've got that oxygen toxicity. Also, chest pain. They can start having chest pain beneath the sternum. Okay. Usually, it's just below the sternum. They're going to start having that chest pain. And then finally, GI upset. Okay, nausea, vomiting, that sort of stuff. The big one you'll see, though, is constant non-productive cough. That's what you'll see first, and hopefully we can kind of treat things and recognize it before then, before it gets too bad anyway. As the exposure continues, symptoms are going to become more severe. So you're going to just kind of keep, and usually what happens, patients struggling to breathe, what's our first reaction? Give them more. So we give them more, and what happens? Keep getting worse and worse and worse. Okay, that's another sign. If you give oxygen to a patient and they get worse, you need to start kind of investigating things a little bit. All right, they will eventually start to develop decreased vital capacity. Did we talk about vital capacity last week? Okay, we'll get to it today. But vital capacity, what do you think it might be? Okay, usable amount of oxygen. Okay. What it's talking about is, we talked about the lungs. What do they do on inspiration? They expand. Okay. We're going to talk a little bit later about compliance. This is sort of it. Compliance is that ability of the lungs to expand and then expel the oxygen, or hopefully not expel the oxygen, but expel the air, CO2. Okay. That's what we're talking about there. Decreased vital capacity is the ability of those lungs to expand and fill with air. Okay. Then we'll start having crackles, and then also hypoxemia. The key here, prolonged exposure to high levels of oxygen can damage the tissues. If we damage lung tissue, that's not good, right? We definitely don't want to damage any tissues. We'll talk about, especially with COPD and some of these other conditions, but you damage lung tissue, then you've got a lot of problems, and that's kind of what leads to that decreased compliance. All right, some other things, absorption atelectasis. This is new onset of crackles, also the decreased breath sounds, and then also drying of the mucous membranes. What's one of the functions of the respiratory system? Yeah, well, it doesn't cool it. It warms and humidifies. Okay, so it warms and humidifies the air coming in. If we're just keep pumping in more and more air, I don't know about y'all, but if I sleep with a fan, I usually have to sleep with a fan because I get too hot, but that's that drying of the mucous membranes. Well, you're going to look at the values, okay? You have to reduce the amount of oxygen you're giving. The dyspnea is occurring because of that, well, overuse of oxygen. The percentage is too high, so they'll start backing them off of it. Yeah. Mm-hmm. Now, eventually, in that situation, usually you're going to call the physician. Well, when you give them more oxygen, say you've got an order. At this point, if we're giving oxygen, we've got an order, right? So if we are giving oxygen, we've increased it still within those parameters, but the patient's getting worse, we're going to call the physician back and say, hey, look, it's not working, it's not helping, what do you want to do? And in that case, we've got you got to give them the signs, right? So you're identifying these signs of oxygen toxicity and feeding that to the doctor or the practitioner or whoever. I'm sorry? You would call a physician, because they're going to tell you, for one, they're probably going to tell you to draw an ABG, or probably not you, but they'll order an ABG level to be drawn, and that's going to evaluate what? That's an arterial blood gas. Okay, we're going to look at the PaO2. All right, the arterial oxygen level, and you'll see it. If it's too high, usually it starts getting way on up there. They're going to say, "Oh, that's our problem. We're going to back off on that a little bit." All right, and then the drying. So the drying of the mucous membranes, one of those functions, humidify and moisten. Okay, or well, humidify is moisten, right? Humidify and warm. All right, so we need to provide that. How can we, during our oxygen therapy, prevent this from happening? We humidify with a water bottle. Okay, if you ever go into a patient's room, they're on oxygen. Hopefully, if they've got a lot of oxygen going on, if they've had it for a while, they've got a water bottle. You hook it up, and you'll hear that constant bubbling that occurs. That's what's preventing the drying of the mucous membranes. All right. If you walk in the room, you got a patient on oxygen, and they're complaining, "Hey, I feel like I'm dried out. Maybe their nose is bleeding some." That's a pretty good indicator. They got drying of the mucous membranes to the point. Let's get them a water bottle. And that's something. If they've got oxygen ordered, you can let the nurse or whoever respiratory know, and they can get them a water bottle. Okay. And then finally, infection. Why would infection be a potential complication of oxygen therapy? Okay. Well, it's a route where it gives infection and bacteria a route straight to the lungs. Okay. So therefore, it's a good or not a good indicator. It's a potential complication you have to assess for. Especially if you're taking care of a patient maybe on a trach, you're giving oxygen through a trach. That's an even more direct route, and we've lost the upper respiratory system that filters some of that stuff out. Okay, so just remember that. That's also a complication that you've got to consider. All right, we talked about this a little bit while ago, but assessment of oxygenation, ABG analysis is what we're going to use. Okay, you may not always use ABGs because they're kind of they're painful. For one, for them to check the ABG level is pretty painful, but that's the best way. Okay, best way to determine the need for oxygen therapy. Now, SpO2. SpO2 is going to be a venous stick. All right, venous stick. They can also evaluate venous concentrations of oxygen. It's a little less invasive. You can do it with a normal blood draw. Okay, but that's probably what they are actually going to most likely have ordered to evaluate, but the ABG level is going to be the most accurate. All right, and then SpO2 is going to be that's basically that's going to be your pulse ox. All right, when you walk in the room, you put a pulse ox on the patient, you're evaluating the SpO2. Okay. All right, what's our normal SpO2? 95 to 100%. Yeah. Are there any alterations to that? COPD. Okay. You got chronic patients. Yeah. A lot of times their SpO2 or their oxygen saturation is going to come down a little bit. Have you ever heard of a patient, normal healthy patient, perfectly fine, satting lower? Is there ever an occurrence that you can think of when that might be true? So if I go and I put a pulse ox on a patient, what are we doing with a pulse ox? Okay, we're evaluating capillary oxygen saturation, and it shoots a laser through the skin to evaluate the bounce back, right? Okay, absolutely. If they have fingernail, there you go. I'll give you credit for it. Fingernail polish. All right, fingernail polish. Are there any others? All right. What is it having to go through? The skin. Okay. Individuals with darker pigmented skin, they may actually have a lower oxygen saturation. When we're looking at it from a SpO2 standpoint, we're shooting a laser through an oxygen saturation. they may be 3 to 5% lower on a normal oxygen saturation. They're perfectly fine. Their 95 is 100%. Does that make sense? So just a lower saturation from the beginning. All right. All right. So now, what would you think of? Okay, I walk in the room and I see my patient is having trouble breathing. What characteristics do you think I would see? Respiratory distress. What are the characteristics of respiratory distress? Okay. And what was that? Gasping. Okay. All right. Use of accessory muscles. Okay. Cyanosis. Okay. What's cyanosis? Bluish discoloration around the mouth. What other skin changes? Pallor. Pale discoloration. All right. What else? Anything else? What if it's been going on for a little while? Maybe they've really struggled to breathe. What may we also see? Kind of as a late sign. Okay. Yeah, if it's a chronic patient, you'll see the barrel chest, the clubbing of the fingers. But if you've got an acute patient that may be over an hour, they've really struggled to breathe, there you go. That's what I was looking for. Changes in mental status. All right. And the elderly. That may be one of your first signs for the elderly. Changes in mental status. Okay. All right. So here's some of these that we've talked about. You got our dyspnea, nasal flaring. Okay, and also the use of accessory muscles. All right. Pursed lip or diaphragmatic breathing. What is that? What's pursed lip or diaphragmatic breathing? All right. Kind of a natural body reaction. If you can't breathe, what happens? You start kind of breathing in real quick through your mouth and out. And then also, what are you doing? All right. And what position do you typically go to? Tripod. All right. You're leaning over. Okay. That's the natural body positioning that occurs when you can't breathe. Okay. Natural reaction. You'll see that. All right. Also, what about if I look between the ribs? What am I going to see? Possibly retractions. I heard it somewhere. Retractions. Okay, you're looking for retractions. All right. All right. So retractions. You see the skin pulling in. Okay. Everything is trying its best to bring as much oxygen as it possibly can in. All right. So that's what you'll see. All right. And then the skin mucous membrane changes we talked about. We skipped decreased endurance. That's definitely. This patient can't even really complete a sentence. You ask them what's wrong, and they're just, can't you see? I don't have to tell you. I can't breathe. Okay, they can't even complete a whole sentence. Usually, if you're asking them a question, they're going to respond with yes or no. Quick answers. They can't complete that sentence. And then finally, the change in mental status, irritability, and restlessness. They just can't get comfortable. All right, and then they're confused. They may not even know where they are at this point, or care, because they can't breathe. That's the only thing they're worried about right now is I can't breathe, fix it. Okay. All right. So, and we talked a little bit about oxygen therapy, but now we've seen that our patient can't breathe. At this point, we're going to assume they've got oxygen. Okay. Now we've got to figure out what type of oxygen we're going to give. You may have a specific physician order for a specific type of oxygen. That's what you got to use. Okay. If not, if they just order oxygen therapy, you can kind of work on it a little bit and see what works. A lot of times they'll order a certain amount. They may say 2 to 4 liters via nasal cannula. If they fall outside of that parameter, you got to call and get another order. Okay, you got to go with what's ordered there. Now the type is going to depend on the oxygen concentration required to achieve what? What do we want to achieve? Yeah. SATs. Our SATs become, well, a lot of times it depends on what the doctor ordered, and it also depends on the patient's condition. We said it kind of depends on the pigmentation of the skin. All these things are factors you have to consider. But, as a general rule, we want at least 90%. Okay, at least know that the tissues are being oxygenated or perfused. Okay. Also, we're going to consider the importance or accuracy in control of oxygen concentration. There's different types that are more accurate. Okay, and we'll talk about some of these. We're going to go one at a time on all these different types. But if we really need an absolute accurate amount of oxygen, there are certain types we'll need to look at. Particularly like in an NICU setting, NICU babies, that kind of thing, or even COPD patients. We don't want that CO2 sensitivity to be reduced anymore. So if they're on oxygen, usually they're on a set amount, a specific amount to have. All right. Also, patient comfort. Okay, we got to consider patient comfort as well. Now, what comes first, though? Is this going to be our first thing that we consider? No. We got to oxygenate the patient first, but we want the most comfortable, most flexible. All right, the one that gives them the most flexibility in terms of mobility. All right, give them some extra tubing if we can. And why would we want to give them extra tubing? So they can get up and walk to the bathroom, so they can walk around the room. Consider that. Okay. Usually, if you've got a patient on oxygen and they're not on bed rest, you kind of want them to get up and walk around. Maybe it'll help, everything as well. Maybe help bring them around a little bit. We also have to consider the importance of humidity. We talked about that. We want to make sure we put a water bottle on if we can. And then patient mobility we just talked about. All right. Now let's talk about a few of these specific systems. Most of them you've seen, but there's some important characteristics you have to remember about some of these. First, some of the low-flow oxygen delivery systems. And this is not completely accurate, because low-flow oxygen, you can have a face mask with as high as you possibly can. So I'd put nasal cannula on the low flow. I don't know if I'd consider face mask on there, but nasal cannula can give you 1 to 6 liters of oxygen. All right, so if I put a patient on a nasal cannula and I go above 6, what's happening? Nothing. They're only getting 6. Okay, so if a patient requires more than 6 liters of oxygen, we can't put them on a nasal cannula. Okay, so we talked about if we keep increasing oxygen and they're not improving, well, you may need to check this too. If you got them on nasal cannula and you put it to 7 or 8 liters, you're still giving them 6. Okay, so be mindful of that. All right, some of the different types of face masks: simple, partial rebreather, and then non-rebreather. And we'll talk about each of those here in just a second. But the nasal cannula, again, flow rate's 1 to 6 liters. This is a concentration of 24 to 44%. And again, flow rate greater than 6 liters is not giving them anything extra. You want to assess the patency of the nostrils. If the patient has nostrils that aren't patent, are they a candidate for nasal cannula? No, it's not really doing them a whole lot of good, right? You also want to assess for changes in respiratory rate and depth. All right, next we've got a simple face mask. This delivers oxygen up to 40 to 60%. Now, here's a key. You need to star this. Minimum of 5 liters per minute. So if I put a patient on a simple face mask and I put them on 2 liters, what's happening? I'm not giving them any oxygen. What am I doing? They're probably suffocating a little bit, right? I'm impeding their ability to bring in oxygen. Okay, because I'm not giving them anything extra. All I'm giving them at this point is room air. All right. Be sure that the mask fits securely over the nose and mouth, and then monitor closely for risk of aspiration. Again, you must have it at 5 liters or you're not giving them anything. Okay. Next, we've got a partial rebreather. This provides 60 to 75% of the flow rate of 6 to 11 liters per minute. Now, the key here: 1/3 of exhaled tidal volume with each breath. What that means is we're giving them extra oxygen every breath. Okay, extra oxygen. So every time they exhale, we're still pumping in more oxygen. Okay, we're bringing it back into them. We adjust the flow rate to keep the reservoir bag inflated. The key here is we're able to give them more or a higher oxygen concentration. All right, and then finally we've got our non-rebreather. This is the highest oxygen level. It can deliver FiO2 greater than 90%. It's used for unstable patients requiring intubation. Usually if you've got a patient on a non-rebreather, the next step is intubation. Okay, so we're either going to try to get them off of that and bring them down a little bit, or get them intubated. Okay. Now, here's another important point. Ensure that the valves are patent and functional. Okay. And you'll see these flaps over here. If you've got the flaps closed, which is kind of what you need there, you're bringing in all the oxygen they're getting is from an outside source. They're not breathing anything from the air. Okay? So what happens if we turn off that oxygen? Leaving this on, leaving the flaps closed, and we take off the oxygen supply. They get nothing. They're suffocating. It's basically the same as taking a pillow and putting it over their face. So that's very, very important that you are aware. If you've got a patient on a non-rebreather, you need to watch them real close. Because all it takes is for them to maybe move around or fight something or, jerk that cord on the oxygen. No, because they're not getting anything other than 6 liters. And now, look, they may have a specific one. I don't know. Just a basic nasal cannula. They're not getting any more than 6 liters. Yeah. Unless it's just some kind of special nasal cannula, they should be switching over to a mask at that point. Yeah, because at that point you're getting 6 liters. I don't know about. And they've got some other types. I think there's some kind of like a, what do they call it? Some kind of like dog bone something. Supposedly a little easier. I don't know. There may be some new techniques and new methods, but just a basic nasal cannula is going to give you 6 liters because of the anatomical dead space. But yeah, make sure if you've got a patient on a mask of any kind, but particularly this non-rebreather, make sure you've got the oxygen at least to the 6 liters, okay, and make sure that it's functioning properly. Well, you can give up to 11 liters. Well, no. Now, a simple face mask, I'm trying to think what the simple face mask is going to give you. 5 liters is what you really look at. If you need more than that, you need to be on a non-rebreather, or the partial non-rebreather. Trying to think what the actual percentage is. 5 to 8, there you go. So that's what it is, 5 to 8. You can't give all the way up to the 11. If you go more than the 8, that's when you got to work on the partial non-rebreather or the non-rebreather. And the non-rebreather, again, you're giving nothing but what you're giving to them is what they're receiving. Okay, it's 90 to, well, I don't think it'll get up to 100%. It's close, it's 90% or so of oxygen on the non-rebreather. There's only one setting on that one. When you've got the non-rebreather, you turn it wide open. Okay. All right. Now, some of our high flow, and again, some of those others are probably going to fall into the high flow as well. But the high flow oxygen delivery systems can give 24 to 100%, 8 to 15 liters per minute. All right. First, we've got the Venturi mask. The Venturi mask is an adapter located between the bottom of the mask and the oxygen source. If you've been in the clinical setting, you may have seen one of these. It's just kind of the tube that sticks down from the mask. It delivers precise oxygen concentrations and is the best source for chronic lung disease. So if you've got a COPD patient, very, very commonly they'll have this, because we want a very accurate percentage of O2, precise concentration there. As tolerated, these patients can switch over to a nasal cannula during meal times. We do want to encourage, good caloric intake, but again, they got to make sure they can tolerate it. Okay. All right. Next, we've got a T-piece. A T-piece delivers FiO2 for tracheostomy, laryngectomy, and ET tubes. Okay. So if you've got a patient on some type of tube, breathing tube, that's what they'll have, and it just basically clips onto the actual tube part. Now, one thing is you want to make sure that you ensure humidification. With this patient, with any type of tube, particularly, well, for one, they're bypassing what? They're bypassing that upper respiratory system. They're bypassing the body's natural humidification and warming mechanism. Okay, So you've got to provide that. Mist should be seen during inspiration and expiration on these. All right, some of our other, I guess, methods. This doesn't always have to have oxygen attached to it, but it is it could provide oxygen as well. The non-invasive positive pressure ventilation. Basically, we use positive pressure to keep the alveoli open to improve gas exchange without airway intubation. So CPAP, BiPAP. Okay. Even during exhalation, we're still pumping in some pressure to keep those alveoli open. All right. Remember, that's one of the main issues, especially for patients following surgeries. Close the alveoli, they collapse, and then maybe they lack the surfactant to keep them open, or they have some kind of tissue damage that prevents the alveoli from opening back up. Well, that positive pressure keeps them open at all times. Okay. CPAP is going to be a continuous positive airway pressure. The patient receives a set amount of positive airway pressure throughout the breathing cycle. So inspiration and expiration, they're still getting that pressure to keep the alveoli open. Now BiPAP is just a little bit different. It's bi-level positive airway pressure. The difference here is the pressures are different. Okay, bi-level. Okay, the patient receives a set positive airway pressure during inhalation, and then a different level during exhalation. Okay, this is kind of a step up from the CPAP. All right. Now here's a look at a CPAP. Yeah, it's basically just pumping that pressure back to it, and it keeps it open in a way. I don't know exactly how it works, but it's able to keep that pressure constant, even as they're breathing out. I don't know exactly how it's going to work, but you are going to have that pressure that keeps it open. Normally, if you're exhaling, you're taking away all your pressure and everything's collapsing, right? So that's I don't know exactly, but that's the idea anyway. Is everybody good with this one? Okay. All right, there's a look at just a CPAP, basic CPAP. All right, and we talked a little bit about this with the transtracheal oxygen delivery. This is a long-term delivery of oxygen directly to the lungs. A patient that's chronic, that's got long-term issues that are going to require maybe a long-term trach. This is when we would pass a small flexible catheter into the trachea through a small incision. It avoids irritation the nasal prongs cause and is more comfortable. So this is your trachea or tracheostomy tube. Okay, this is what they're talking about there. The patient is going to have long-term levels of oxygen. It can kind of take away some of the irritation. Flow rates are prescribed for rest and activity. Basically, it protects the airway and keeps the airway patent. Okay, this is a patient that may be some kind of chronic, not even chronic, a traumatic brain injury. Some type of I don't know, some type of chronic injury that's going to cause that that they have airway instability, tracheal instability. So this keeps that trachea open and patent. All right, now, when they're going to have a tracheostomy placed, the tracheotomy is the surgical incision into the trachea for the purpose of establishing an airway. The tracheostomy is going to be the stoma. Okay, this is the opening. This is what we always kind of refer to. We're talking about tracheostomy care. Well, we're cleaning and taking care of that stoma. It results from the tracheotomy. It may be temporary or permanent, depending on what the patient's needs are. This is a look at the location where it would occur. They're going to go between the second, third, and fourth tracheal rings. Now, some of the priority nursing considerations. Okay. Reduced oxygenation. That's always a concern. A patient with a tracheostomy may or may not have to have supplemental oxygen, but we do have to monitor for that. Also, inadequate communication. How do you think it's going to alter their communication ability? they have to relearn how to talk. In some cases, they may not be able to learn how. There are some devices that I'll show you that they can use, and it helps helps with communication, passing your valves and different things like that help kind of push air over the vocal cords. But again, that's something we have to consider. When they come out post-op, they absolutely have no ability to talk. Okay, so what can we do as nurses? Okay, a whiteboard? Absolutely. That's the key. If and now, it's not always possible, but the more you can establish a plan before they go down for the tracheostomy, the better. A lot of these patients are not, they may not be able to speak beforehand. They may not be able to communicate. They may not even be conscious when they go down for the tracheostomy. But the more you can, the better. Okay. The key is planning. The most you can. Also, inadequate nutrition. We want to promote wound healing. Usually, if the patient's having trouble breathing, they're having respiratory issues. They need adequate nutrition. Sometimes it's difficult for them to eat, particularly with a tracheostomy tube. They can feel it. If they're conscious and they're trying to eat, they can actually feel the tube. Sometimes it makes it hard to swallow. So if they're having trouble swallowing, what might we do? Okay, may have to alter the diet. Soft foods. What else? Thickened liquids. Okay. We want it to be thick, but not too thick, right? So we have to kind of consider that as well. But again, it may have to. The patient may have to have an altered diet as well. We do want to encourage as much nutrition as possible. They're going to need more calories. They're going to need more protein for the wound healing as well. All right, potential for infection. Again, anytime you have an open, access or open passageway straight to the lungs, the risk of infection is even greater. What are we going to do as nurses to consider that? The risk for infection. Proper techniques. In the hospital, we're going to use sterile technique. Now, when they go home, they're not at risk necessarily for the nosocomial type infections, MRSA, that sort of thing, at home, in their home environment. So they may not necessarily have to do the sterile technique. But in the hospital, we absolutely will. Anytime we access or touch anything related to that trach, we're going to use sterile technique as much as possible. Now, in the event you walk into the room and the patient's trach's out, you got to get your airway, right? So that's going to be the most important thing. But as much as we can, we're going to consider that risk for infection. Okay. Also, the damaged oral mucosa, and this is very, very common. You've got a patient with a tracheostomy tube. This is all you're worried about, right? You forget they even have a mouth. Okay. You can't do that. They'll develop thrush. They'll develop all kinds of stuff. Obviously, cavities and everything else. So you have to consider that. One of the things that you kind of want to do, especially if maybe you're the day shift. Okay, you go in to do tracheostomy care. Go ahead and do some oral care as well. Okay, that needs to be considered. They're almost at even greater risk for the infection by not using the airway, or the mouth. Okay, the upper airway. So you got to consider that. And what type of psychological concerns do you think we would have? Absolutely. Altered body image is going to be a big one, especially if you've got a patient that's completely conscious, completely aware that they have this tracheostomy. Okay, body image concerns are going to be huge. All right, what are some ways we could help with that? Okay, teaching. One, we want to promote independence. We want them to be as independent as possible. We want them to be able to take care, do as much of the trach care as they can. Okay, we can teach them the different methods and techniques. Okay, refer them to a support group, for sure. Let them see, hey, there's a bunch of people out here that have, the same thing I do. And you always, now, on test questions, you always want to consider what you can do first, and then you want to move into referrals, but that's absolutely one of the things you want to do. What else? Would we want to say, well, just cover it up? We could put a Band-Aid over it, or maybe a piece of gauze or something like that. There you go. What's happening if I put a Band-Aid or something over it? You're obstructing their airway. That's their method for breathing in oxygen, right? Now, what we could recommend, maybe not a tight-fitting scarf, but maybe a loose scarf. Something that kind of takes away, from the obvious appearance there. But the key is making sure they use those methods without covering up the airway or impeding their airway. All right. Okay, so now you've got a patient that's actually going down. And hopefully some of these things we've already discussed with the patient, right? We're preparing them for what's going to happen. What can they expect? What are they going to see when they come out? What are they going to feel? But when we get them, so that's kind of our pre-op routine. All right, get them ready. Post-op, number one priority, ensure a patent airway. Okay, ensure a patent airway. Those tracheostomy tubes, they can easily come out, very easily, especially fresh post-op. And what happens if it comes out? Well, we've lost the airway, and what happens to that hole? What happens if you get your ears pierced, and then you take them out real quick and leave them? They grow up, right? That opening will grow up in a hurry. Okay? It changes size quickly. So if a trach tube comes out, you got to get it back in as quick as you can, especially when it's fresh post-op. Okay? So that's your number one goal. You take care of a patient post-op, fresh post-op, after they've just had a tracheostomy tube placed, and you lose that airway, that's your number one goal. That physician's not going to be real happy, is he? Okay? So you got to consider that. You also want to assess for possible complications, including respiratory distress and swelling. Okay? Anytime we manipulate anything in that upper airway, the risk for swelling is there. Okay? What are some ways we could look and monitor for swelling? Okay? Measure neck circumference, absolutely. What else? Look bilaterally, okay. What else? If I'm looking at the actual stoma, what might I see? Okay, it's starting to grow together. That's, yeah. Hopefully we'll leave that. The tube is going to kind of prevent that from growing together, but what might you see at the side? Stretching. You'll see almost the skin tightening and stretching. That's a pretty good idea that, hey, we got some and it's, again, that's skin stretching, but if the skin's stretching, the neck circumference is getting bigger, it's a pretty good idea that maybe the airway is swelling as well. Also, we watch again for the tube obstruction and dislodgement, and we'll talk about trach tube care in depth, probably at nauseum there in the lab, but and we'll even kind of discuss it quickly here. You got to make sure that you've got another trach tube available. Okay, and like we said, it's going to grow up in a hurry, right? So what do you need to have at the bedside? Okay, sterile gloves. All right, what else? That tube, you need to have one the same size and one smaller at the bedside. I know, I was working at Children's, we would have a go bag with all the supplies you needed. Okay, I don't know what they call it here. I don't even know if they have a go bag, but absolutely you would have at least one size smaller, the trach tube one size smaller. We always had one the same size and one size smaller because you want to go with the same size possibly if you can. But if you can't get that one in, you got to get something in there to protect that airway from closing up. All right. What else do you need to have at the bedside ready to go? Suctioning, absolutely. All right. You may not necessarily have to have the crash cart. You need to have one there, at least on the unit, ready to go, though. And hopefully, we wouldn't need it, but definitely the suctioning, definitely the oxygen. Okay. Make sure you've got all your equipment there ready to go. And even the tracheal suctioning catheter is very, very important. You got to have that ready to go. when the patient comes out fresh from a tracheostomy insertion, not a tracheostomy, trach tube insertion, there's going to be a lot of secretions. Okay, a lot of secretions. You're going to have things that, you got to really be stringent on your care and make sure you're suctioning to keep the airway open. One of the stories I got for you. I worked with a nurse, and she was one of these. She hated bacteria. She hated goop, and she was just a clean freak. And she was a nurse, yeah. But I guess that probably made her a pretty good nurse because she washing her hands all the time and all that. Well, she freaked out with any kind of mucus, any kind of secretions, that kind of stuff. So we're in there, and we had a patient that was kind of struggling. She was really struggling. She had a trach tube. This is probably one of the biggest trach tubes I've ever seen. We were at Children's, so a lot of ours were some of the older kids, car wrecks and traumatic brain injuries, that kind of thing. She started struggling, so we get in there and we're trying to get her kind of revived a little bit, and we just can't get her. We can't get her to come back a little bit. We can't get her to bring her sats up. We're suctioning. We're providing more oxygen, all that kind of stuff. Well, she's at the head of the bed, or not the foot of the bed, and I'm over here on the side, and all of a sudden this girl raises up and takes a mucus plug and shoots it across the room. And I look over, and she's got it on her forehead. It's sitting on her forehead. And I'm thinking, okay, she is about to have a complete breakdown in this room and start screaming. She didn't. She quickly grabbed something, wiped it off, and stepped out of the room. Okay? All right. Now, especially in the isolation tables or the isolation carts, the wipes that they've got, and I know I've told some of y'all this, but those wipes that they've got sitting on the isolation carts, at Children's we had a sign on them that said, do not use, or not a baby wipe. Do not use for a baby wipe. Don't wipe it on a kid's butt. I mean, you're going to have problems, okay? There's a reason we put that label on there. She took one of those wipes and she scrubbed. And she scrubbed and she scrubbed and she scrubbed. It's about her hairline here. Well, a bald spot formed in the days after, okay? So I guess the moral of the story, do not take these wipes and put them on anything that you want hair to grow on. And I don't even know what's in those wipes. But yeah, look, they're nasty. They're nasty at times. That wasn't the Clorox, it was the other, whatever the purple ones are. Yeah, Sandy Cleanse, there you go. We just called them It's Not a Baby Wipe because we had these big giant It's Not a Baby Wipe stickers all over them. But yeah, it's, they're nasty at times. Once you kind of get them in a routine, everything is good, the secretions start to dry up a little bit, everything kind of gets back to normal, and they're easier to manage, but that's just the nature of it. You got to be willing to do whatever you got to do to get that. And to give you an idea, okay, the reason we couldn't get that, the airway clear, and she kept struggling to breathe, she had that plug inside the tracheostomy tube, okay? So you got to have one there to be able to change that out. And we probably should have gone to that already. And just change out your trach tube, okay? And that's something you don't have to necessarily have an order for. You use sterile technique, okay? In kind of an emergent type situation, you got to be quick with it, but you try to use your sterile technique as much as you can, and you can just change your tube out, okay? We'll talk about trach changes in a little bit. Preferably, I would recommend always have somebody else with you to help kind of hold things. Be ready. When you take one out, you got another one to go right back in. All right, but that's part of maintaining that airway. Next issue, pneumothorax. What's a pneumothorax? Close. Pneumothorax. Collapsed lung. There you go. Collapsed lung. All right. And we'll talk about a pneumothorax in depth here in just a minute. But it's basically your collapsed lung. The space fills with air outside, and it changes the pressure, collapses the lung. Next, we've got subcutaneous emphysema. Okay, this is not the emphysema you typically think about. Subcutaneous emphysema is when there's going to be a tear or an opening around the site. Basically, you've got air that's trapped. Well, not even trapped, but it moves outside in between. Well, just under the skin. Okay, it moves under the skin, and you can tell this because it's going to basically make a crackling feeling when you kind of palpate around the actual tracheal opening. All right, but it escapes into the space under the skin of the neck, face, and chest. Okay. Next, you got bleeding. Bleeding is expected on a fresh tracheostomy tube placement. You know, when you've got the stoma there, it will bleed some. But now, a lot of bleeding, a lot of drainage is not normal. Okay. All right. So the small amounts in the first few days. All right, and then we got to consider infection. The same reasons we talked about before. Again, it's a direct route straight to the lungs. So the risk of infection is very, very good. We're going to use sterile technique as much as we can. All right, trach tubes. Tracheostomy tubes can be disposable or reusable. In most cases, even the reusable ones are going to be, you know, they got about a month life on them at most, unless you've got a patient that really, really takes care of that tracheostomy tube. Fresh post-op from the placement, they're not going to last very long. Okay, you're going to get the mucus, the plugs and things that kind of collect on them. They can also be cuffed or uncuffed. The cuff is referring to a balloon that goes around the tracheostomy tube. When it's inflated, when the cuff is inflated, it helps hold it in the airway. Okay, it helps kind of stabilize, maintain it there, keep it there, keep it where it needs to be. And we'll talk about that in a minute. The key with cuff, if you've got a cuff in place, you've got to make sure that that pressure is exact. Okay, if you overinflate a cuff, it can damage the tissues. Okay, it can damage the tissues and tracheal tissue there. If you underinflate, it can move around some. All right. You've also got intercannulas that are disposable or reusable. And you'll see that in the lab. You've got some that, you know, you take the intercannula out, you clean it, and you replace it, put it back in. Then you've got some that are disposable. You take it out, you throw it away, and put a new one in. It just depends on the type of the trach. Oh, no. They can do that. I mean, eventually, once they are discharged, that patient or whoever's taking care of that patient, helping with that patient, they can do all of the trach care. We would start teaching as soon as the patient gets back, as early as they're willing to be taught, as early as the family's willing to be taught. We start that teaching almost immediate. The unit I was on in children's, we would get them ready for discharge. I mean, we're getting them ready for discharge from the minute we get back. Usually they had about a 2-week window on the rehab side, but you know, much as they were willing to learn, we taught. And then finally, you've got fenestrated tubes. This is one of the devices that helps with communication. If you have a fenestrated tube, basically it has, I don't know if I've got, yeah, here we go. Okay, a fenestrated tube is here. These little holes in the top of the actual tube, it helps to move air over the vocal cords. Sometimes it works, sometimes it doesn't. It depends on the patient, but they can kind of teach themselves to be able to speak a little bit, even with that. All right, and this is the cuff we were talking about. If they have a cuff, it's inflated. It helps to stabilize the airway a little bit. Usually, well, I don't know about usually. A lot of times, once they go from the ICU setting to the floor, they're going to try to change that out to where they get rid of the cuff. Not always, but in most cases, they try to, once the patient's more stable, they move to an uncuffed trach. All right, some of the complications we've got to consider: cuff pressure. And too much cuff pressure can cause mucosal ischemia. Use minimal leak and occlusive techniques as much as possible. Check cuff pressure often. Usually it's about every shift. And there's a device. You can either use this device or you can actually use a syringe. In most cases they've got one of these, but you know they can check it depending on the need. You want to keep it in the green zone as much as you can. If it's too much, that's a problem. All right, that's when you've got the tissue damage that's occurring. All right. Also, prevent tube friction and movement. You want to make sure that that tube is secure as possible. Okay. You need to check that. Really, every time you go in, you need to check it, make sure that it's not too tight, but also make sure that it's tight enough. A lot of times, especially with these confused patients that require the tracheostomy tube, they're going to have, a lot of times they want to pull at it, they want to yank at it, they're confused, they don't have a lot of awareness of what's going on. You've got to be mindful of that. There's a lot of times, especially in my old setting when I had a bunch of the kids, they're quick to try to pull that thing out. Okay, so you need to be mindful of that. One of the worst feelings in the world is to walk into the room and that trach tube is sitting in their lap, whether it's because they coughed it out or they pulled it out or whatever. You got to get it back in as quick as you can, okay, to maintain that airway. All right, and when you're doing trach care, it's good to have somebody else there with you. If you got somebody else there with you, it seems like every time, if you loosen both sides of the what am I thinking of? The straps. I don't know whatever the straps that hold them in place. Okay, the positioning device. If you loosen both sides, almost every time they will have to cough, and they'll cough the thing out on you. Okay, so you got to be mindful of that. Try to loosen one side versus the other, and then not keep it from coming all the way out. Usually, when you're actually doing the trach care, your goal is to only have to remove that inner cannula. Whether it's disposable, then you throw it away, put a new one in, or if you're having to clean it, take the inner cannula out and clean it, and then put it back. But you keep that tube in place. Okay. You also want to prevent and treat malnutrition, hemodynamic instability, and hypoxia. Again, you're monitoring respirations, or not respirations, but saturations. You're monitoring the respiratory function and perfusion. You also need to prevent malnutrition. Okay, we talked about that before. Make sure that they are taking in enough calories and protein. All right, and we've also talked about this quite a bit. Air warming and humidification. Tracheostomy tube bypasses the nose and mouth, which normally humidify, warm, and filter air. Air must be humidified. You want to maintain proper temperature, and then also ensure adequate hydration. Okay. All right. You already take a break? All right. So now we're going to talk about tracheostomy care and the suctioning that goes along with it. We've discussed the importance of maintaining the airway. This is a very, very important method or aspect of that. All right. Hopefully I'll come back up for you in a minute. But suctioning is extremely, extremely important. You need to be able to do it effectively. You need to be able to do it pretty quickly. Usually if a patient needs suctioning, we're doing that to maintain the airway. Often you have to do it in a hurry. Okay. Frequently what I would, if I've got a patient, it's a tracheostomy patient, I'm going to have some sterile gloves in my pocket usually. I'd pull 3 or 4 pairs of sterile gloves and just have them in my pocket ready to go. Now, you use the sterile gloves as much as you possibly can. If the patient's really having trouble breathing, you got to do things a little quicker sometimes. All right. So when you're trying to figure out whether you need to suction, you need to assess the need in patients who cannot cough adequately. That's the big thing. We're trying to. There are times when the patient cannot clear the secretions. Often. Patients who are struggling with their airway, or they have a tracheostomy tube, they cannot cough effectively. So you have to you have to artificially do that. It can be done through the nose, mouth, or the actual artificial airway. Most commonly, it's going to have to be done through the artificial airway. It's needed when secretions are audible or noisy, when crackles or wheezes are heard on auscultation, with restlessness, increased respirations, increased heart rate, or mucus is visible in the tracheostomy tube. Okay? Commonly, these patients are not going to be able to tell you, hey, I need to have my trach suction. They're not necessarily, even if they are awake and alert, sometimes they don't have that ability, or not, at least not the ease of ability to verbalize that need. Okay, so you've got to assess that. You're looking for nonverbal cues. Okay, the restlessness, increased respirations, increased heart rate, those are nonverbal cues. Patients struggling to breathe. Okay, now prior to actually suctioning, hyperoxygenation with 100% O2 may be necessary to prevent hypoxia and improve patient tolerance. Again, this has to be a patient-by-patient determination. You got to make, you got to ensure that the patient is for one able to handle it, okay, and then two, make sure that you hyperoxygenate, give them the oxygen they need, because during the procedure they lose that ability to oxygenate. All right, you want to monitor oxygen sats for heart rate and blood pressure, or other signs of hypoxia during the procedure to make sure that they're tolerating it. Okay, very, very commonly, you'll suction and you'll have to resuction. But in most cases, you're going to have to wait a little while. Okay, you suction, give them 30 minutes to an hour, and then you can resuction. Okay, it's very rare that you're able to just continue to suction and suction and suction without giving them a break. All right. The standard trach suction catheter for adults is 12 to 14 French. Sterile techniques should be used in the hospital due to the risk of nosocomial infection. You'll lubricate the catheter with sterile water or sterile normal saline and insert the catheter the length of the trach tube without applying suction. That's the important part. You do not apply suction on insertion. Okay. Now, insertion is going to be about the size of a trach tube. Okay? If you have a question about how big the trach tube is, look at the one that's at the bedside. Okay? Because you're going to have one that's at the bedside, right? Should have that one ready to go. Emergency procedure. You need to look at that, and you're going to use, usually, I don't know, that long. I mean, that's not far. You don't have to take it and stick it down to their gut. All right? You know, you're going to kind of compare. I'm sorry. That's deep suctioning, and they will, and you probably you're not going to use that much. The problem is it goes down and it damages the tissue past that trach tube. Now, there are times when you absolutely have to get the patient breathing again. Yeah. Yeah, and look, as a routine, you're not going to do that. But you do have deep suctioning, and you got, I mean, here's what they teach. The standard practice is the length of the catheter. Respiratory therapy, I mean, they'll do some deep suctioning at times. I'm not going to say evidence. The standard practice is the size of the trach tube. You know, you have to adjust and do what you got to do, get them breathing. But that's what you need to go in thinking. Okay. So, using a sterile technique, you lubricate the catheter, you insert. You do not suction until you are withdrawing the catheter. Okay? And then it's going to be intermittent. What does intermittent mean? Yeah, it's not constant. You know, when you pull out, you're not going to leave it on there and pull it out. Okay? Intermittent, usually use a swirling motion or whatever you want to call it. You're twisting on the way out and intermittently suctioning. Okay? That's the key. You do it as you withdraw the catheter, that's when you do the suctioning. It prevents the damage to the tissue on the way in. All right. Now, the other key is you don't have to be down there suctioning for 30 seconds to a minute. 10 to 15 seconds should be all your suctioning on the way out. Okay? Again, I've seen deep suctioning where they're taking it down there and they're really trying to get 10 to 15 seconds on the way out. Okay? You want to limit the amount of, well, I guess lack of oxygen, the period of deoxygenation for the patient as much as possible. Okay? Particularly if the patient is requiring oxygen and you have to remove that oxygen to suction, that's time that they're not getting that oxygen. Okay. Now, after the procedure, you're going to re-oxygenate the patient. If the patient's really, if they're really needing oxygen, you're going to re-oxygenate with 100% O2 as well. Okay. Usually the ambu bag is what you would use, well, almost always. You got the ambu bag ready to go. Crank it up to 100% oxygen. You pre-oxygenate, hyperoxygenate before, you suction, and then you re-oxygenate after. Okay. All right, some of the complications you've got to look for. We talked about these. Hypoxia. Okay. You take away the oxygen source, you put something down in their airway, they have a limited ability to breathe at that point. Okay. Hypoxia is a big result there. Also, tissue mucosal trauma. If you insert too far, if you suction on the way down, you could cause damage to the airway. Now, this is the tissue we're talking about here. We're not talking about, break on the outside of the skin or something. This is tissue inside the airway. And what happens when a patient, well, what happens if you get a scar? You damage the outside of your skin and you scar, what happens? It stretches, it changes shapes. I got a big scar here on my finger. I mean, it changes that shape. Scar tissue grows, right? If you have scar tissue on the inside of your airway, it's less compliant. Okay, it becomes resistant to movement. It becomes resistant to airflow. Okay, so that's very, very important. We don't want to damage the inside of the airway. All right, next we've got infection. If you're not using sterile technique, if you contaminate the sterile catheter, you're putting bacteria straight into their lungs. The risk for infection is really, really high. Next, we've got vagal stimulation, bronchospasm, and cardiac dysrhythmias from induced hypoxia. Okay, it's a real issue. Commonly, these patients are on a cardiac monitor just for that reason. They can go into these, the vagal stimulation and the bronchospasm real easy. Okay, and then also those cardiac dysrhythmias that can result from that, from the lack of oxygen. Okay. All right. Now, some of the causes of hypoxia we talked about: ineffective oxygenation before, during, or after; use of a catheter that's too large for the artificial airway; prolonged suctioning time; excessive suctioning pressure; and too frequent a suctioning. All right. Again, you don't want to suction 5-6 times in a row. Usually it's you suction once, maybe insert once or twice, and then you give them a break, 30 minutes to an hour. I mean, you let them fully recover. And again, patient to patient, that may change the length of time. You just have to consider the individual patient. No more than 3 times per suctioning attempt is kind of the general rule. All right. Yeah, now, look, if they're in acute respiratory distress, you got to do what you got to do. The girl I was talking about with the plug, I mean, we had to do whatever we got to do to get her breathing again. So, in an acute situation, you got to, that's number one, right? Airway. You just got to consider, this hypoxia is a big issue too. So be right ready with the ambu bag, And even in an emergent type situation, sometimes the reason they're still struggling is because they're lacking that oxygen, maybe not necessarily the secretions. So you got to consider both. Kind of a dance there. You got to work with both. All right. You've also got, well, that covered all that. All right. Now tracheostomy care, and this is the skill you're going to have to be checked off on. You'll have to learn it. But tracheostomy care procedure, it's extremely important for all patients who have a tracheostomy because, for one, it reduces secretions that collect in the tracheostomy tube and clears the airway. It maintains patency of the airway, prevents infection, and promotes effective wound healing at the trach site. You got to think about it. If you've got a patient with just some other type of wound, some other type of incision, you're going to perform care on the open wound, aren't you? Same thing here. The risk of infection is huge if you do not really take good care of this tracheostomy side. Pretty self-explanatory, right? If not, because they get nasty. They get really nasty. And sometimes the general rule is once a shift, or once every 8 hours. Now that they've gone to, the 12-hour shifts, usually every 8 hours it needs to be done, at least. Now, again, it's patient. You're going to have to kind of consider the patient. Some of them you may have to do every 2 to 4 hours. Some of them you might get away with every 12 hours. The general rule is every 8 hours, trach care needs to be done. Now, this is the nicest, prettiest trach tube you'll ever see. They're not going to look like that very often, even after you do trach care. Some of them, I mean, you can clean them all day long, and they just look nasty. It's just part of it. Okay. This is probably a patient that's had it in there for a long time. Everything's kind of nice and dried up, and he's managing his secretions pretty well. Probably may even be able to cough, which, hey, that's always a plus. If they can cough it up, you don't even have to have the suctioning. But this is what it should look like when it's nice and clean. Okay. At least a variation there. You've got the trach holders. That's what I was looking for earlier. Trach ties. Okay. Trach tube holder. Here you've got your inner cannula. This is the part that should stay there unless you're actually changing out the trach tube. Okay. So the inner cannula will come out, and then you'll have this, the tube part, the base, I guess, whatever you call it, would stay in place. Okay. Then you've got a gauze pad. The gauze, preferably you've got pre-split gauze because it just saves you a step. If you had to, you can cut it, cut a 4x4. Most trach kits, especially in a healthcare setting now, are going to have the pre-split gauze pads. For one, it helps keep the frayed edges from being all over the place, and it's just, keeps it nice and pretty. All right, that's what you're going for there. Now, the trach care procedure, I'll let you go through this, take a look at the different steps. We're going to go through this in depth next week, or I don't know, not next week, whenever your checkoffs are. We'll go through this in depth. You can kind of read through these, be familiar with this at least a little bit before we get there. It kind of helps sometimes, but at least be aware of it. Now, if there's any discrepancy between this and your sheets, we're going to use your sheets. Okay, so be mindful of that. I tried to do this as close to the sheet as I could, but I may have, you got to understand on these, with all these skills in the actual setting, there's different ways to do things. There's different ways. Now, the key, and this is what I would be looking for, I want you to be safe. All right, consider the safety of the patient. You do anything unsafe, it's probably not going to be a good check for you. Okay. All right. Mm-hmm. Mm-hmm. Oh yeah. I mean, you can have. You're talking about from the spit into. Yeah. When you're suctioning, you'll have stuff there. Well, I mean, if you're doing, you're just using suction, you're going to have the canister. Yeah, it goes in the canister. You don't have a special canister or anything like that. Yeah, and you can observe it coming out. If you have one that's filling up that canister, yeah, you got a lot of secretions. You're not going to have enough usually to record. It's not going to be like, and we'll talk about chest tubes in a minute. You're not going to have like chest tubes where you're pulling out 40, 50, 100 mLs a shift. It's not going to be like that, hopefully. If not, boy, you got your work cut out for you if you've got that many secretions coming out. All right, so with tracheostomy care, you also have to consider the bronchial and oral hygiene. We talked about that a little bit, but you want to turn and reposition at least every 1 to 2 hours. Support out-of-bed activities, okay? Unless there's something that the physician said, hey, we need to stay in bed, or there's some other contraindication, get them up, move them around, And a lot of patients are nervous because they got this, for one, body image stuff, going back to psychosocial, but also they're afraid to do anything with it. You know, if you need to hook them up to an oxygen tank, by all means, you know, get them up moving around. That's always good for their pulmonary toilet. Get all that stuff out as best you can. Okay, coughing and deep breathing. Again, if you can get them up, you know, you kind of take away some of that. But also, coughing and deep breathing is very important. Chest PT, vibration, also postural drainage to promote pulmonary cure. Okay, extremely important. You do want to avoid glycerin swabs or mouthwash containing alcohol for the oral care, and also assess for ulcers, bacterial fungal growth, and then infection. You know, it's a huge component. You gotta really monitor for those signs of infection. MRSA is really bad with trachs. You know, the likelihood of them getting MRSA is pretty good, but you want to limit that as much as possible. All right. Next, we've got nutrition. And again, we talked about this a little bit, but swallowing can be a major problem for patients with a trach tube. If the balloon is inflated, it can interfere with the passage of food through the esophagus. Thickened liquids may be necessary. Before they go home, you want to assess their ability, you know, assess the likelihood of them to aspirate, assess their ability to you know, swallow and you know, also maintain secretions and things like that. But particularly related to nutrition, make sure that they can swallow. Okay, if they're coughing or gagging or, you know, having trouble, you may have to thicken those liquids a little bit. Usually, these patients will go for modified barium swallow, you know, to evaluate, you know, how effectively. Because the last thing we want is more stuff going into the lungs, more risk of aspiration when they've already got such a great risk for pneumonia and infection and things like that. One important thing. Elevate the head of the bed for at least 30 minutes after eating to help prevent aspiration during swallowing. You also want to encourage foods high in protein to promote wound healing. And it also may be necessary to offer more frequent meals to ensure adequate caloric intake. These things are kind of with any respiratory compromised patient that's struggling to bring in adequate calories. Okay, so a patient with COPD, you may have to offer more frequent meals. You may have to do the high-calorie, high-protein foods, you know, to ensure that adequate nutrition. All right. And then finally, we've got, well, not finally, but next thing with tracheostomy tubes, we've got communication. Providing the patient with the ability to communicate is extremely important. All right. Use alternate forms of communication. We talked about the dry erase boards, hand signals. Okay, thumbs up, thumbs down, you know, that sort of thing. Move the patient closer to the nurse's station. And then also, in this case, you would want to provide yes and no questions. Or, well, ask yes and no questions that they can easily answer. Now, there are some adaptive tracheostomy devices that we talked about, the fenestrated tubes, the speaking valves, there's a Passy-Muir valve, things that help them to, it just kind of fits on the outside of the tracheostomy tube. For a patient that does not require oxygen, this is an excellent resource, or not resource, but device that they can do, and it helps them to actually speak. You know, that helps a lot, especially with that psychosocial aspect. And then finger occlusion technique. Basically, they put a finger over the tube when they want to talk. Again, this is not something that they come out knowing how to do, but they can work with it some and learn those things as well. The key is, you know, let them know that these services or devices are out there. Things that can help with that communication process. You know, they don't know unless they've maybe had somebody that or a loved one that's, you know, going through this, but they don't know it's out there. You got to be there to kind of help guide them through that process. Now, tracheostomy tubes can be, temporary. If we're going to take out a tracheostomy tube, there's specific procedures that need to be followed. First and foremost, the cuff is going to be deflated first. So if the patient is on or has a tracheostomy tube with a cuff, they'll deflate the cuff, usually try to see how they tolerate that. And then if they can tolerate it fine, then they'll swap it out to an uncuffed trach. Once they've tolerated that, then they'll go down in a size, usually. 6.0, they may go down to a 5.0. Lets that the stoma start to heal back. We talked about it. It'll close up in a hurry. Some patients will come out with these big, giant tracheostomies that, they really have to kind of size them back down. They're just huge, almost gaping holes. They'll start kind of gradually decrease that size as much as they possibly can. Now, once they've been, they've reduced the size, they've tolerated without the cuff, then they'll try capping. Okay. The universal, I don't know if it's on that picture I had back there, but the universal cap is going to be red. Okay. When you walk into the room, if you see a red cap on the end, that lets you know that tracheostomy tube is no longer that patient's airway. Okay. This patient is breathing on their own using the upper respiratory system. All right. Now, if the patient's doing fine and you walk into the room and they've got a red cap, do not take it off. Okay? Usually it's there for a reason. But on the other hand, if you walk into the room and the patient's just really, really struggling to breathe, if they're gasping for air, hopefully it's your patient, so you're not having to worry about taking it off. You can take that cap off, and then that's now an open airway. Okay? It may be that they just can't tolerate the capping. You can remove the cap, provide oxygen by the tracheostomy, or the tracheostomy tube, and that allows them to breathe again. That's something to consider as well. Just remember, if that red cap's in place, that patient is not using that as an airway at that time. So if they're struggling to breathe, you can take that off. But once they've tolerated it for 24 hours without respiratory issues or difficulty, the tracheostomy tube can be removed. And it's a simple thing. They take it out and put a gauze and tape dressing on it. They're not doing an occlusive dressing. They're not doing a Vaseline gauze. They're not doing anything like that. All it is just a straight dry gauze they put over the site and tape it. We used to get aggravated as doctors. Sometimes they wouldn't even tell us. We'd walk in the room and now they've got a gauze and tape dressing over their old trach site. That'll kind of freak you out a little bit when you walk in. You're expecting to see this trach in place, and now it's just gone. But yeah, it's real simple once they actually decide, yeah, we're going to remove it. Okay. All right, and finally we've got chest PT. Chest PT is something you're probably not going to do a whole lot of. We do teach it to CF kids and patients with chronic stuff chronic respiratory issues. They will teach them to do self PT or chest PT, and then also family members to do the chest PT. But it's a combination of chest percussion, vibration, and dependent drainage positions to help to loosen secretions and promote their drainage. Now, this is a pretty good image of chest PT and the different positions and the way they're kind of breaking stuff. That's basically what it is. You break stuff up so that it can be, expelled by secretions. Okay. Now, another part of this, you also want to make sure that turn in coughing and deep breathing. You want to encourage that pulmonary toilet to get all that stuff out. Help move air in. Promote inspiration and exhalation. Use of all of the lung fields as much as possible. Okay. All right. Yeah, they'll do the taps. Then they also do kind of a vibration. In most cases now, they've got the little vibration devices, but they'll put it over there, and it basically does the vibration itself. It can be a long process if you're sitting there having to actually do the tap and then also the vibration. Yeah, and all these lung fields. Basically, you're trying to hit every single lung field. Well, yeah, it's going to be the doctor's call. You're not going to take it out unless you got the doctor's order. But yeah, they're going to use certain standards that they want to see. Usually 95 to 100% on room air. They don't want to see, Now there are situations where they will take it out if the patient's able to kind of breathe with maybe home oxygen or something like that. But usually they like to see pretty good SATs because they don't really want to use the oxygen. It's a lot easier on the system if you use the tracheostomy tube to give oxygen. So it just kind of depends. Depends on doctor's preference usually. Sometimes you're not necessarily ready for them to take it out. The next thing you know, you walk in the room and it's gone, and it's like, oh, what am I doing now? I mean, if something goes bad, so it makes you as a nurse kind of nervous. All right, so that's got the kind of the A&P of the respiratory system. Now we're going to kind of go a little bit further in depth with acid-base balance. All right, and we talked about this last week, but it's really important to kind of understand. Some of you weren't here last week, so you may get another recap. But again, the normal pH of the blood, 7.35 to 7.45 of the arterial blood. Okay, the venous blood, 7.31 to 7.41. We don't look at the venous blood quite as much when we're talking about pH. But really, the one we want to focus in on is the arterial blood. Okay. With the ABG levels, this is our focus here. Okay. Now, the body wants to stay in a homeostatic state. Okay. Everything's going to be done to keep everything nice and calm and normal. pH is one of these. The body's going to work to keep the blood between 7.35 and 7.45 on a pH. Some of the changes to that pH can affect the shape of hormones and enzymes, the distribution of other electrolytes, fluid and electrolyte imbalance, and also excitable membranes. Okay, become more excited and more of an excited type state. And then also the effectiveness of hormones and drugs can change depending on that pH. Now, from a chemistry side of it, you've all had chemistry, right? No? Not at all? Okay, well, we don't have to have too much chemistry here. Acids release hydrogen ions when dissolved in water. Bases bind with hydrogen ions in solutions. And then buffers are critical in maintaining normal body fluid pH. And you'll see how we kind of work off of those. But acids versus bases. Different things happen when the blood is in more of an acidic state versus a more, is alkalinic even a word? I think it's basic state, I guess, is what you would go with. All right. Yeah, anytime you've got a release of hydrogen ions, you're going to be more acidic. Okay. Now, the body's going to compensate. It's going to attempt to correct blood pH changes. Okay, so if the pH goes down, more acidic, things are going to happen. All right. Specifically, usually, well, we'll get into that in a minute, but usually CO2 is kind of a manipulator there. The respiratory system is going to manipulate CO2 when the metabolic system is off. There's an alteration. When the respiratory system's off, the metabolic system, specifically the kidneys, are going to start to work to bring things back to normal to compensate for a faulty respiratory system. Okay. So the respiratory system is more sensitive to acid-base changes and can begin compensating in seconds to minutes. The kidneys are more powerful. They're not quite as sensitive, but they're more powerful when they start to work. They result in rapid changes in extracellular fluid composition and are fully triggered for imbalance of several hours to days. So in several hours, alterations of several hours, pH changes for several hours, that's when the kidneys are going to really start working. All right, respiratory compensation. When chemical buffers alone cannot prevent blood pH changes, the respiratory system is going to be the second line of defense. Now, the respiratory system, again, manipulates CO2. If the pH is more acidic, the respiratory system is working properly, it's going to blow off CO2. CO2 is acidic. Okay? So, and I think I've heard one of these little, I think it's simplenursing.com. Everybody look at simplenursing.com? Pretty good. He calls CO2 carbon dioxide. Okay? Carbon dioxide. Carbon dioxide is very acidic. The more CO2 you have, the more acidic the blood is going to be. Okay? So, to compensate, if the respiratory system is working properly, if the pH level is acidic, it's going to blow off CO2. Okay? That's its job. Increase respirations, blow off CO2, so the pH comes back up. Okay? Now, hypoventilation, when we hold in more CO2, it causes the pH of the blood to fall. Okay? All right, everybody with me here? So if we lower the respiratory rate, what's going to happen to the pH? It's going to go down. All right, let's see. Okay? If we... All right, so now this line. If we increase CO2, what happens? pH also goes up. Okay? If we decrease CO2, pH goes down. Okay? It's a direct correlation. The more CO2 you have, the lower the pH. Good catch. See, I was checking, testing it. The more CO2 you have, the lower the pH. Yeah, there you go. So I guess it would be an inverse correlation. pH goes down as CO2 goes up. CO2 goes down, pH goes up. There you go. All right, so 7.45 on this side, 7.35 on this side. All right. So how do we blow off CO2? When CO2's up, we blow off CO2 by increasing the respiratory rate. Okay, does that make sense? All right, now, if CO2 is down and pH is up, all right, we are in an alkalinic state. How can we reduce the pH? Well, we're going to reduce the respiratory rate. The opposite. Okay? Does that make sense? I know I confused you with the first one, but you know what? You kind of picked it up, so that's good. All right, so our body's response to increase CO2 is to increase the respiratory rate. It's also the response to decrease pH. Okay? Our body's response to increased pH and or low levels of CO2 is to reduce the respiratory rate. Hypoventilation. Okay? All right. Everybody good with that so far? All right, that's all dealing with the respiratory system. Okay? All right, next. We've got the kidneys and the metabolic system. All right, metabolic compensation. This is the third line of defense against pH changes. It's stronger for regulating acid-base levels, but it takes a little longer to get started. Okay? Kidneys move bicarb. That's its ability. Move bicarb in and out. The higher the level of bicarb, the higher the level of pH. Okay? So this is a little different. Okay, so now pH goes down as bicarb also goes down. Okay, bicarb is a alkalinic property or chemical, whatever, substance. Okay, as pH goes up, so does bicarb. Okay, or well, I'm sorry, these are causes now. Okay, we're talking about causes now. We're not talking about compensation. But if the bicarb level goes up, the pH level is also going to go up. Okay? I don't want you to get confused with that yet. All right? The kidneys control how much bicarb is in the system, therefore manipulating the pH. Okay? All right. Now, bicarb is a weak base. It's a major buffer of the major buffer is of the extracellular fluid. It's mostly done from intestinal absorption of ingested bicarb into the extracellular fluid. Kidneys absorb and break down carbonic acid into the bicarb. Okay, I don't want you to get too bogged down in all that. All right, just know that the kidneys can manipulate based on the amount of bicarb in the blood. All right, manipulate pH. That's its system, and that's how it can manipulate the blood pH. All right, now let's get into actually interpreting ABG levels. Okay, and I know we talked about this a little bit. I need to just pull up this chart, don't I? We're just going to go back here to the end, okay? And then we'll come back to the rest of this. Because I don't want you to get too confused with all the physiology and the patho and all that. You do need to understand how the body does it, but the big thing is being able to identify these alterations, okay? I know this is a review for some of you, but interpreting ABGs, we've got different states here. pH, when the pH goes down, we become more acidic. The blood becomes more acidic. Okay? When the pH goes up, it's more basic or alkalinic, alkalosis. All right? CO2, the higher the CO2, the more acidic. So you got to flip that number on this chart. Okay? So CO2, as CO2 goes up, we become more acidic. Alkalosis, as pH goes down, we become more basic. And then bicarb goes in correlation with pH. As bicarb goes down, pH goes down. As bicarb goes up, we become more basic for alkalosis. Okay. So with this chart, this is kind of the way I would recommend. This is probably the easiest way I found students kind of pick up how to interpret these ABGs. But let's say I give you some scenarios here. Let's say I've got a pH of 7.34. Okay. I've got a CO2 of 46. And I've got a bicarb of 27. Okay, so pH 7.34, CO2 46, and bicarb of 27. All right, now I'm going to put a check in the box that applies. Okay, so I've got my chart up here. What's my pH if it's 7.34? Is it normal, acidic, or alkalinic? It's acidic, so put you a check mark in the pH. Okay, CO2. All right, and this is down, right? So acidic. Okay. Now my CO2, is it normal? Is it acidic? Or is it basic? It's basic. Yeah, it's acidic. There you go. It's acidic because it's up. And CO2, when it goes up, which side does it go to? There you go. pH goes down, but it's going to be on the acidic side. So now we've got a check mark in the pH side. pH acidosis, and we've got a check mark in the CO2 acidosis. All right, now let's look at our bicarb. We've got a bicarb of 27. What's our normal 21 to 28? Is this acidic, alkalinic, or normal? It's normal. Okay, and that's another point. But right now it's normal. Okay. All right, so it's normal. Where does my check need to go? Okay. It's not acidic, it's not alkalinic, so it's normal. So we've got a check mark in the normal box. Now, let's look at our result now. We've got a pH that's what? Acidic. So what do we have? Acidosis. Okay? We know that right now, because if the pH is abnormal and it's below 7.35, we have acidosis of some kind. Okay? So that's our first step. Next, we've got to figure out where our problem occurs. Is our problem with the respiratory system, or is it with the metabolic system? So you've got to look at which check goes right in line with the pH. Okay? So right now we've got one here, we've also got one here. So we've got 1, 2 lined up. Okay? So we know we have what kind of problem? The respiratory. The respiratory system, CO2, is lined up with the pH. So we have a respiratory problem. So we know we've got respiratory acidosis. We know that 100%. Okay? The CO2 is causing the pH to be abnormal. That's what we know. Okay? Now the third part is we got to figure out whether compensation has occurred or not. Remember, one system, respiratory and metabolic, they kind of work, hopefully, they work opposite of each other to compensate. So if one issue, if the respiratory system is causing a problem, the metabolic system says, okay, I've got to fix it. Okay, I got to do something to fix it. So now I've got respiratory acidosis. My bicarb is normal. So is it doing anything to compensate? At this point, no, because it has not moved abnormal either direction. Okay? So compensation, we're either going to have three choices. As far as compensation goes, it's either going to be compensated, which means the pH has now been brought back to normal. It's uncompensated, which means nothing's moved. The third number, or the third unit, in this case bicarb, has not moved yet. So that's uncompensated. Or partially compensated means that third unit is moving to affect the pH. Okay, to make up for the respiratory problem. Okay, so now, if we've got a bicarb now of 27, which is normal, we've got a check mark in the pH acidosis, CO2 acidosis. The bicarb is normal, so therefore we have what? Uncompensated respiratory acidosis. Okay, does that make sense? Usually you can get this real easy. Where the problem is and the pH. You can get the acidosis or alkalosis. The compensation usually kind of gets a little confusing. You got to do a bunch of them to kind of figure it out. Especially if you just get three numbers and you don't see the movement either direction. Okay? It takes a minute to figure out. Okay? Well, we'll talk about it in just a minute, but it takes a minute. Okay? Yeah. So that's a good point. So let's say this one is now, the bicarb has sensed a problem with the respiratory system. It picks up on the pH being altered. So the kidneys, probably the kidneys are picking up on it, but the kidneys are going to start moving. Okay? They're going to do what? It's acidotic. So which direction is the kidney, or well, is the bicarb going to do to compensate? It's going to start going up, right? Okay? Because we want to go in opposite. If it went down, what would happen? pH would go even lower. We don't want that. We want it to go in the opposite direction. So it goes up. So now let's say it's 29. Okay? Now, is this normal, acidotic, or alkalinic? It's at 29. It's up, so it's abnormal on the alkalinic side. Okay? So now, this one, remember that seesaw? Now the seesaw, we're throwing some bicarb on the other end of the seesaw to try to bring that pH back to normal. Okay? So, alkalinic, kidneys sense it. Well, kidneys sense the acidosis. Add bicarb so that we become more alkalinic than what we were to bring the pH back to normal. Now, is the pH back to normal though? Okay? So we know compensation has occurred because bicarb is altered. Okay? So there has been some compensation. Now you have to look back at the pH to figure out whether it's fully compensated. And fully compensated means that pH is back to within normal range. In this case, it's 7.34. Is it back to normal range? No. So it's partially compensated. Okay? Partially compensated means that third unit has recognized the problem and started moving, but it hasn't quite got it back to normal yet. Okay? Does that make sense? All right. Any questions so far? Sure. Yeah, the question was if you can go back to the normal numbers. All right, now, kind of moving with this same problem. All right. Compensation has occurred. We've got bicarb has moved up. CO2 is still up. It hadn't detected the problem because it's the problem. Okay. Respiratory is the issue. Now let's say our pH moves back to 7.35. Now, is 7.35 normal, acidic, or alkalinic? It's normal right now. 7.35 is normal. It's kind of on the verge, but it's still normal. Okay? Now I have to figure out, well, it's normal. It's on the acidic side of normal. Okay? But it's still normal. CO2 is up, so there's been a problem. Okay? Something's altered that pH. So we've had compensation because it's normal. Now we got to figure out, okay, is it a respiratory problem or a bicarb problem? Okay? Because we haven't seen this progression. We just see the numbers. So if the pH is on the acidic side, where's CO2? The acidic side. Bicarb is up. It's abnormal, but it's on what side? The alkalinic side. So we know that's not the problem. That's the compensation. All right? So it's still a respiratory problem. It's still respiratory acidosis, even though it's still normal. It's on the respiratory acidosis side, but compensation has occurred because the 7.35 is normal. So it's fully compensated respiratory acidosis. Okay? Does that make sense? All right. You still have to kind of line it up. And even if you say, you know, you got your grid here, if it's normal and you just want to kind of put a mark maybe in the middle. Yeah, it's normal, but everything else is off. But it's on that acidic side. So now let's see which one was acidic. Is more acidic. Okay? Because that's still where the problem is occurring. All right? Does that make sense? Any questions right now? All right, let's try another one. Okay? I'm going to try to give you just some random numbers here. All right, now let's see. I've got a pH at 7. All right, my pH is 7.45. My CO2 is 48. And my bicarb is 29. So I've got 7.45, CO2 of 48, and a bicarb of 29. Now, let's go piece by piece. Are we normal, acidic, or alkalinic? Okay.
What's normal, but it's only out.
All right. So if it helps, do normal alkalinic. That's fine. Y'all are anticipating, right? So it's normal. That's the key, though. 7.45 is normal, but it's normal on the alkalinic side. Okay? Now, CO2, is it acidic, normal, or alkalinic? CO2 is up, which is acidic. Okay? All right, so if you're doing the grid here, I should have just had a grid that I could manipulate it, but so far I've got an X here on normal, maybe on the alkalinic side of normal. I've got a CO2 that's up, which is acidic. Now my bicarb. I've got a bicarb of 29. Is bicarb normal, acidic, or alkalinic? Alkalinic. Because what's my normal range? 21 to 28. So 28 is normal. Well, this one's 29. So it's abnormal, it's up, which is alkalinity. All right, so now let's interpret it. What's going on here? All right. Right now, I've still got a normal pH, okay, but it's on the alkalinic side. Here's the key. If you get to this, it's normal, but everything else is off, you know there was something that occurred, okay? Well, it's on the alkalinic side. Which value is also on the alkalinic side? Bicarb. All right, so I've got my pH over here, kind of normal alkalinic, CO2 over here, bicarb over here. So pH is moving with the bicarb. So what type of problem do I have? Metabolic alkalosis. All right, now I've got to determine compensation. Okay. Has CO2 moved? Yes, it's abnormal. Okay. pH, is it back to normal ranges? Yeah. So we know CO2 is what moved to make it normal. So it's fully compensated. And a lot of times you'll just see compensated, but fully compensated since we're using partially on the other side. All right. Does that make sense? Got a question? All right. Any other questions? And we're going to do one more to practice, but okay. I want you to get this. I know it's kind of a weird concept. You're going to have to kind of play around with it. All right, so now let's do one more. Let's do .48 on a pH. Our CO2, let's do a 37, and our bicarb, let's do a 29. All right, first, pH. Normal, acidic, basic. Basic, because it's up above, what, 7.45. So it's over 7.45, it's abnormal, and it's basic or alkaline. I'm still not sure that alkaline is the word, but that's what I've been using. All right, so y'all know what I'm talking about. It's probably easier to understand than basic. All right, CO2, is it normal? It's 37. It's 37 normal, acidic, or alkalinic? It's normal. Okay. Now our bicarb, HCO3, is it normal, acidic, or alkalinic? Alkalinic. All right. Is it's what? Up. What's our normal value? 28. Okay. And so 28 or up and above is what? Alkalinic. Okay. So now what's our problem? All right. We know we've got alkalosis. What's causing the alkalosis? The metabolic. We got too much bicarb, so it's causing the pH to go up. We've got metabolic. All right, now we've got to figure out compensation. Has compensation occurred? CO2 is still normal. That CO2 said, we're all right. We're not worried about it yet. All right. CO2 said 37, hadn't started moving. So we are normal, so uncompensated. We got uncompensated metabolic alkalosis. Okay? All right. Once the compensation occurs, what's going to happen? When the CO2 recognizes this as abnormal, what's it going to do? All right. CO2, respiratory system says, whoa, we got alkalosis going on. I want to bring the pH back down. So what am I going to do? The CO2 says the pH, yeah, and that's the problem. The CO2 is flipped. So for the CO2, the respiratory system, to make the pH go down, it has to increase CO2. So how does the body increase CO2? It decreases the respiratory rate. And I know, I threw you a flip, I know. But to compensate, the respiratory system is going to recognize that as too high of a pH. So to bring the pH down, it's going to drop the respiratory rate, which will do what to CO2? Increase CO2. Anytime you drop your respirations at night, your CO2 level is going to go up. Anytime you lower the respiratory rate, CO2 level is going to rise. Okay? All right. That makes sense. That's how the body, the respiratory system, is going to compensate in this situation. Metabolic alkalosis. Okay? Because remember, we want to increase carbon dioxide if the pH is up. And the body does that by decreasing the respiratory rate. Okay? The respiratory rate's going to act quicker. Yeah. It's just not quite as potent. You'll see that. Yeah, you'll see that a lot. One of the most common occurrences when you'll have the pH alterations is diabetic ketoacidosis. Okay? The body, the metabolic system, is reacting to increased glucose levels. Okay? And it becomes more acidic. The blood becomes more acidic. Okay? So the body blows off CO2 with, well, what they call Kussmaul respirations. Fast, deep respirations. They're trying to quickly get that CO2 out. So they have abnormal CO2 levels as a result of that acidosis. But yeah, you'll see the manipulations of the respiratory rate. Now, there are normal changes to this. I mean, the pH is going to change up and down in a normal person. The problem is when that almost the buffer system stops working. You know, when it stops working normally. Okay? When you have alterations, you know, respiratory alterations are going to affect pH if they're not corrected. Okay? And the metabolic system is what has to do the correcting. Because there's an alteration in the respiratory system. All right, does that make sense? Last thing I want to do is make you more confused. All right. If you have trouble with this, go home and just, you know, I'm sure you can find some problems in the book somewhere. You can find them. If not, call me and I'll feed you some examples here that you can go through. Okay, but you got to practice this stuff. Recognize it. All right. We're going to talk about that now. And probably what I should have done is started with this again, because I know y'all's heads started spinning when I started talking about how the body does this. And, you know, part of that is, you know, you need to be aware of it. But, yeah, kidneys are going to pump bicarb in if they need it or take it away. And we'll talk about it a little more in depth. All right, but everybody's got this part of it, interpretation. Okay. At least to some extent, huh? All right, so now let's look at all right, so now we've talked about when we interpret the problem. Now let's talk about how we're going to react once it gets there. You know, once we figure it out. All right. Okay. So now, acidosis. Okay? We're talking about acidosis. And now, there's two different types. There's metabolic. With metabolic acidosis, we have an increase in hydrogen ions, free hydrogen ions. It's either from an overproduction or under elimination. So we don't get rid of enough hydrogen ions, or we hold too many in, or, well, overproduce them. Okay? This could be a result from renal failure. Okay? With renal failure, we have decreased urinary output. decreased filtration, decreased work of the kidneys. Okay, so we don't get rid of the free hydrogen ions that are a result of this. Well, we'll talk about it in a minute, but you're talking about the production of bicarb. Okay, bicarb ions underproduction. All right, underproduction of bicarb ions or an over elimination of the free bicarb and hydrogen. All right, then you've got respiratory side. Respiratory side deals with CO2. Okay, when respiratory function is impaired, it causes a problem with oxygen and CO2. Basically, with respiratory acidosis, we don't blow off enough CO2. Okay, we hold too much in. All right. Also, we retain CO2. This could happen as a result of respiratory depression. Also, inadequate chest expansion. We talked about decreased compliance earlier. The ability of the lungs to expand, but also to contract and do what? Blow that CO2 off. Okay. Also, airway obstruction. You obstruct the airway, you diminish the airway not only for the oxygen to come in, but for the CO2 to go out. And then also reduced alveolar capillary diffusion. That diffusion, so, what happens during diffusion at the alveoli? Gas exchange, which is oxygen goes from the lung to the blood, and then what happens? CO2 goes from the blood to the lung. Okay, if you have an imbalance in that diffusion process, you can have retained CO2, increased CO2 levels. Okay. Now, our interventions. This is what we're going to do if we recognize. Well, it's not acidosis, but the acidosis. If we have a recognition of either, in this case, respiratory acidosis, the focus is going to be on improving ventilation and oxygenation. Okay, we want to improve the ability to bring in oxygen and get rid of CO2. Maintaining a patent airway. That's kind of number one on all this stuff, right? Make sure that patent airway is patent. Drug therapies include bronchodilators, anti-inflammatories, and mucolytics. Okay, all these are goal, or I guess the goal of all of this is to make the airway nice and open and most applicable to bring in the oxygen and get rid of CO2. Oxygen therapy. We increase the oxygen concentration, helps us to decrease the CO2. Pulmonary hygiene, ventilation support, and then also prevention of complications. Okay. Our patient-centered care, we want to get a good health history. Why do we want to get a good health history in this occurrence? Yeah, if they had this problem in the past, for sure. Are they prone to have these metabolic or these respiratory issues? Okay, what chronic conditions do they currently have? We want to find out also their body's ability to compensate. If you've already got a metabolic issue, and then you add on a respiratory issue, that may potentiate the problem. How well is your body equipped to be able to handle the problem? All right. Also, CNS changes. We want to really look at CNS changes. Why is the neurological system important here? Well, it affects everything, absolutely. What else? Why did we say the brain's important? There you go. If you have a neurological problem, it can cause a respiratory problem. Okay? If the brain's not able to recognize high levels of CO2 and do what with the respiratory system? Increase respirations to blow off CO2. If it doesn't recognize that problem, it can't compensate. Okay, that's the whole reason the metabolic system has to step in. So you got to figure out, okay, what's the problem? What's the underlying cause of this issue? And then you also want to look at neuromuscular changes as well. You're looking at decreases in muscle tone, deep tendon reflexes, cardiovascular system. You're going to look at increases in heart rate. Usually, if the respiratory system has to ramp up, cardiovascular system has to too, right? Because you can bring in all the air you want to for oxygen, but if you don't have a way to transport it to the tissues, it's not going to work. Okay, bring it in all day, but it's not going to get any better. Also, with worsening or sign of worsening respiratory distress respiratory acidosis, you're going to have hyperkalemia. Okay, increased potassium. Also, what happens when we have changes in potassium? That's when you've automatically got to start looking at dysrhythmias and cardiac changes. All right, some of the signs you'll see T-wave peaks, also QRS widening. And I know y'all haven't had the cardiac stuff yet, have you? You'll see that a little more, but these changes are pretty important. You've got to be aware of them. If nothing else, put them on a cardiac monitor. Okay, in most cases they're going to have that going. Look for weak peripheral pulses and also hypotension. Okay. All right, from the respiratory system, and we've said the respiratory system is going to, if normal, respond to acidosis by increasing respiratory rate, small respirations, fast, deep respirations. Try to blow off as much CO2 as possible. Okay, skin changes from the skin changes from either metabolic or respiratory. You're going to have warm, dry, and pink skin as a result of the vasodilation. Okay, everything's kind of well, the vessels are opening up so they can get as much stuff or nutrients, but also the oxygen to the cells. All right. Psychologically, how do you think it's going to affect you psychologically? Yeah, there you go. It goes back to what we talked about last week. Somebody pulls you underwater, and you feel like you just can't get enough oxygen. Because that's the feeling that these patients get. They feel like they can't get enough oxygen no matter what. That's why their brain is saying, "Oh, we got to keep breathing faster and faster and faster and faster." So they really feel like they're almost, well, they're hyperventilating. They are. They're hyperventilating. Okay. Produces anxiety. Produces, restlessness, confusion, and all that kind of stuff. All right. Now, specifically with metabolic acidosis, hydration is going to be a key. Okay. We want to hydrate. Increase the fluid levels. This will help with the acidosis itself. Also, drug therapies. DKA is going to be your big one. Metabolic acidosis, diabetic ketoacidosis is going to be your most common type of metabolic acidosis. Okay, kind of goes hand in hand. I know you haven't had the diabetic section yet, but this still kind of goes hand in hand here. When our blood glucose levels go up, okay, does anybody know what happens? Yeah, we got too much sugar that's not being used, right? Yeah, we got all the sugar we need. Problem is the body's not using it. So what happens? That's exactly right. Yeah, the body is not able to use the glucose, so it resorts to, okay, well, if I can't have sugar for energy, I'm going to resort to, fats. Fat breakdown is called ketosis. Okay, ketosis in turn decreases the pH, causing acidosis. Okay, but the body's response to hyperglycemia is polyuria. So we're flooding out. Everything's leaving. Okay, it's draining us of all of our fluids. So we want to, for one, we want to get the blood sugar down. We also want to hydrate. Increase intake, whether it's through oral intake, also maybe IVs, depending on how bad the acidosis is. Usually if they're being treated for acidosis, it means it's gotten to an abnormal state. Okay, fairly abnormal. And I know we're getting into diabetics, but again, you can't keep it kind of in a nice little tube here, and you got to talk about it a little bit too. But the polyuria, then you got polydipsia and polyphagia. That's kind of the body's response to, I can't get enough energy, so I need to eat. Okay, polyphagia, and I'm losing my fluid, so I need to drink. Polydipsia. Okay, and it just keeps making it worse and worse. That's right. All right. Also, metabolic acidosis antidiarrheals. Okay, why do you think that would be the case? Yeah, if a patient, this is kind of separate from, diabetic ketoacidosis, they could have that in conjunction, but increased diarrhea is going to deplete acid stores, not stores, but the acid in the stomach. Okay, that's kind of where a lot of it breaks down, and it can really lead to the acidosis. So we stop the diarrhea. Sometimes it helps our pH come back up, and then bicarb. If we give bicarb, usually it's kind of they're in a pretty bad state, but this is going to be really with severe low serum levels. Okay, we can actually give supplemental bicarb. Kidneys aren't given, compensating enough. That's the problem. So we can actually add in bicarb. Okay. All right. With alkalosis, with metabolic alkalosis, this means we have an excess of bicarb. This could be either from excessive intake of bicarbonates, carbonates, acetates, or citrates. Or it could be a result of acid deficit. And this is kind of what we talked about a while ago before. Prolonged vomiting. Okay, if we vomit out too much, okay, too much of our acid goes away. We have our pH to go up. Okay. Also, excess cortisol, hyperaldosteronism, thiazide diuretics, and then prolonged NG suction. Okay, this is a side effect that we may cause. We've got to monitor that. With respiratory alkalosis, this could be the result of hyperventilation due to anxiety, fear, improper ventilation settings. Okay, the patient's on a ventilator. We have it adjusted wrong. Maybe the doctor ordered it wrong, or we adjusted it wrong. Based off of that order, we can cause too much respirations, which causes too much CO2 blow off. Also, stimulation of the central respiratory system or center due to fever. So an alteration of the neurological system could cause the alkalosis. Okay, could cause us to breathe too fast. Brain's telling us to breathe too fast. We breathe too fast, causing the alkalosis. All right. All right, patient-centered collaborative care. All right, what we're going to do, we want to assess closely. Assess, and this is going to be the same for both metabolic and respiratory alkalosis. You're assessing for hypocalcemia, hypokalemia. So again, changes to potassium. We're looking for what? Cardiac dysrhythmias and cardiac changes as a result. Also CNS changes. Okay. Positive Shozovex and Thosio sign. Muscular changes including tetany, and then respiratory changes. What respiratory changes are we looking for with alkalosis? Okay. Well, if the patient's in an alkalinic state, the respiratory system is going to decrease. Everything's going to be depressed there. Okay. All right. Now, what are our interventions? What do we do for a patient in alkalosis? Well, we want to prevent further losses of hydrogen, potassium, calcium, and chloride ions. Okay. Because the more of those we lose, well, the alkalosis is only going to get worse. We want to restore fluid balance as much as possible, monitor changes, and also provide safety. And then also modify or stop gastric suctioning, IV solutions with base drugs, and also drugs that promote hydrogen ion excretion. Okay. All right, and again, this is a look at our diagnostic sheet. So this is what we're looking for related to ABGs. All right, PaO2, we want it to be between 80 and 100. Okay. pH, 7.35 to 7.45. Back to this PaO2. If you have elevations over 100, what could that indicate? We talked about earlier. Yeah, oxygen toxicity. So that's what we're looking for. We have a patient that comes in, well, not comes in, usually they've been there a little while. We're giving them oxygen, and they start with a what? What's the sign of oxygen toxicity we look for? Okay, constant non-productive cough. Okay, they start with that constant non-productive cough, and then so we come and we order an ABG level. The PaO2, if it's above 100, that could indicate, hey, we're giving too much. Or even on that side. Remember, this is not a percentage. Okay, this is a level here. All right. This elevations indicate possible excessive oxygen administration. Decreased levels indicate possible COPD, asthma, chronic bronchitis, cancer of the bronchi and lungs, cystic fibrosis, respiratory distress syndrome, anemias, atelectasis, or other causes of hypoxia. All right, and we've looked at the pH, 7.35 to 7.45, CO2 bicarb, and then this final one down here is SaO2. This is actual saturation. Okay, so this one is a percentage. This is 95 to 100%. This is the inside the artery. What's the oxygen saturation? What's the percent of hemoglobin molecules that are bound to oxygen? Okay, and this one should be 95 to 100%.